So, after a thorough evaluation of the case, how should you plan the treatment? The first phase will be, of course, an endo-perio management. And we start with endo because, that's that's important. We first treat the endo, see that everything is fine. I mean, you could also do a little superficial scaling and supragingival scaling before you do the endo. But before you go on and do a deep cleaning or a subgingival curettage or whatever you call it in a particular case, depends on. It's better that you finish the endo before that. It's important that endo is done so that it not only will you will see that there is a difference in the sensitivity that the patient has, if at all he has, but you will also see that the overall mobility of the tooth will get better. Uh, Phase two will be to place the implants and, of course, to do the aesthetic oral rehabilitation because you're extracting all hoopless teeth and placing implants. You can do an immediate placement as well. Provisional restorations which are planned before so that you can stabilize the teeth as well as give the solution to the patient instantly. He can go and he doesn't have to be embarrassed without teeth. And then, of course, wait for a sufficient long period for everything to heal well before you make the final restorations, which can be tooth supported and implant supported. So this is the overall action plan with which you proceed. And it is important now to understand a few things about flaps procedures also. When do you actually advise a flap procedure? Is it always necessary? And the answer is no. Do you always put a bone graft? Answer is no. Of course. When you want to eliminate the pocket, the depth of the pocket is huge. And I don't mean to say that only the inflammatory part of it, but the overall pocket depth is more. So you do a supragingival scaling and then the gums get better. Then you look at still what is the depth of the pocket and you feel the pocket is still quite large. You want to eliminate it? Yes. You want to see that the bone defect is something that you have to work on. You need to go deeper. You can't reach with your instruments. You have furcation involvements. You probably need some grafting procedures and reconstructive procedures for that area. You need to create a favorable tissue contour for maintenance. You're doing some resective osteosurgery there, or you also want to do crown lengthening. So these are the reasons where you may advise a flap procedure and not just do deep subgingival curettage and root planing. The key is to facilitate access for thorough debridement, removal of subgingival deposits, granulation tissue, plane the roots, and recontour the bone. So as long as your objectives are met, you could do that procedure. You need to understand as clinicians that there are certain instruments which are absolutely important. And most of you would be using these instruments. You need to have good irrigation. You should have good ultrasonic scalers as well. You need to decide how to splint the teeth if they are mobile. And you should have enough anaerobic antibiotic coverage. But very important for you to understand is that splinting is not something that you want to do on very mobile teeth. The overall tooth should be such that it can be kept there without mobility if you can splint them, and the periradicular structure of the bone is sufficient enough to keep the tooth for a few years. Because if you're going to just splint hopeless teeth, it might not work on the long-term perspective. So you need to be very, very realistic about your objectives. Many times clinicians call the periodontist when actually it is time to make implants. Periodontal therapy has to be done any time from initial infection of the gums to the time the mobility starts. That's the best time to treat patients. Once you have mobile teeth and they are hopelessly mobile, that's not the time when a periodontist needs to work on them. That's the time when the implantologist has to take over. So sometimes your diagnosis is delayed because you don't see minor periodontal problems. So to develop an eye to see the slightest periodontal disease is very important as restorative dentist. Your success lies in that. So here are some pictures that are showing you eliminating of um, the pocket after reflection of the flap and debriding the areas, cleaning the root, maybe doing some osseous recontouring of non-supporting bone, creating a favorable bone contour, irrigation, cleaning up the defect area. Many people have advised some treatments there, but you know yeah, there is no real 100% solution. You can use grafts, there are multiple grafts available in the market, and then you can also use a membrane covering that as well. So you could use the favorable graft material. It could use something which does not resorb so fast. It could be a xenograft like BIOS. You could use a membrane. This is a procedure of guided tissue regeneration. And the purpose of this procedure is to reduce the long junctional epithelium into a favorable periodontal attachment. So idea is that we want to eliminate the pocket and we don't want a long junctional epithelium to form there. So which defects to graft? Vertical defects, interdental craters. You need to understand which will hold or retain the bone grafting material. Defects which have got more than 2 or 3 walls, vascular walls, hopefully. Grade 2 fractions. You don't want to graft on areas which are not going to be retentive. You're not expecting the grafts to hold if you're putting too much pressure on the soft tissue. You need to understand that the soft tissue will follow the bone wherever possible. So you need to be within the confines as much as possible with the height of the surrounding bone. You can be ambitious. Theoretically, you can do so much. Practically, you can only go a certain level. You have to be very practical with that, especially when you're dealing with teeth situations. Now the next job is to place implants. Of course, the implants that you will place hopefully will be tapered implants because they're going to be used in between teeth as well. They need to have great primary stability, so that the implant design has to be very good. The implant coating has to be good because you want great bone adaptation around them subsequent to their healing, but that will happen if the surface is such that allows blood cells to bind very close to the surface and the micro gap is reduced. I always advise submerged healing protocols for such cases. You can be heroic, but heroism doesn't work because our patients want long-term solutions. So if you're heroic, be heroic on yourself, on your family members. If you're true to what you want to do, treat cases on their own merit. Don't try to over leverage and get glamorized by immediate dentistry. It can be done. Of course, we do all-on-4, trefoil, so many things. But you need to understand the indications, contraindications, the occlusal design, and then decide which can be done with immediate loading and which should be done with a delayed protocol. Protocols for immediate implant placement in periodontally compromised sockets could be a traumatic extraction of the teeth, thorough debridement of the socket wall, removal of all granulation tissue, very carefully with small curettes, irrigate constantly with normal saline, cold saline, minimum reflection of the flap. Keep the periosteum intact as much as possible. And of course, obtain primary stability in wide sockets by engaging implants at least 2 millimeters to the apical bone, and in narrow sockets by enlarging lateral walls. So primary stability in narrow sockets obtained from the lateral wall. Try to keep the implant at least a millimeter subcrestal to compensate for the resorption of bundle bone. It could be less than a millimeter as well, depends, because it can't be uniform. You know, the socket wall is never uniform after extraction. Implant placement subcrestal will help. Position of the implant should be placed bodily towards the palatal or the lingual, leaving a gap in between the buccal wall, because the buccal wall is usually the thin wall and you don't want to pressurize this area. If at all this defect on the buccal side is more than 2 millimeters, I would use a graft. Something like a xenograft again, something like a BIOS, which will not resorb so fast, which will hold on, which will give rigidity to this area, and which is predictable. It's worked very well in practice. And then you wait for everything to heal. You look at the bone formation, and only when you're sure that everything is fine, and usually it's 17 weeks, the sigma of the bone, you evaluate the bony contours, look at the implant bone interfaces, and then you're happy with everything, the gums look nice. That's the time when you make impressions, proceed with your restorations, which can be indirect or direct. Transfer is a good way of doing it. Direct abutment level impressions also can be made for people who don't have good labs. So you could do that. The transfer can be made, and then in the patient's mouth you could use these lab prepared abutments. Carefully evaluate the inclination of the abutments in relation to each other and adjacent teeth, and then proceed with the final solution. If the abutment level impressions are made, carefully torque each abutment, ideally before the impression procedure. Block the access hole with a plumber's tape or a Teflon tape and a provisional restoration. Make it look like an abutment. See that the margins are supragingival wherever you can, and make a good elastomeric impression. Make another alginate impression to guide the technician to understand whether there is any error in the elastomeric impression. Take the vertical records as you have planned by making provisionals as your stop points wherever possible, so that you have take the vertical in multiple records rather than one single record. We can go easily wrong with a single record. And understand that when you're preparing teeth or the implants, you are honoring the biologic width. Your attachment should be healthy. There should not be any infiltration of disease in that area. You don't want any inflammation coming in because of violation of biologic width. You need to be very, very sure that you're there. You should be at least 3 millimeters away in natural teeth up to the bone height to maintain a good biologic width of 2.04 millimeters. So all these considerations are important. So when you're doing all the phases of preparation, impression making, you should be thorough with what's going on. Preparing teeth which are long, exceptionally long because you lost bone, you are going to be on the roots. Of course, these teeth are treated with endodontics. The margins can be very thin, knife edge, feather-like. So you just flute the margins and try to make supragingival margins wherever possible. The posterior teeth, supragingival will be the best margin if it's fused beautifully. For aesthetics, of course, we don't want it there, but for function and for longevity of restorations and periodontally good environment, a supragingival margin will work the best. And that's why nowadays a lot of people want to go on for onlays rather than full crowns, wherever possible for single teeth or multiple teeth as well. And now I think it's time for the second question and answer session.